Many renowned people, Dr. Travell, Dr. Dawson, just to name a few. She's certified in neurodevelopmental therapy. She's attended the International Acupuncture Training Center in Beijing, China. She has certificates in acupuncture, traditional Chinese medicine. She uses needles to affect the ANS and stimulate the CNS to relieve pain. She's trained and certified in myofascial release, craniofacial therapy, myofunctional therapy, Buteyko breathing methods, dry needling, neuromuscular re-education, active release, core exercises. I'm synapsing this is a lot longer actually. She completed the 1-year orofacial pain TMD program at UMDNJ. And this is really important, she's board certified as a CCTT, certified cervical temporomandibular therapist. So she's internationally known for her soft tissue diagnosing, treatment, and complex issues in pain management. Please help me in welcoming Carol Cote.
And thank you for having me join you this evening for this opportunity to share my education, my interest, and my results. If I'm here, I'm representing my patients. And collaborative approach is where the answer is. I will say the name of this course was created by nobody else but our Michelle Weddle. I was talking to her the other day. She says, Carol, you know, this is PT course. This is an intro course. So I thank you, Michelle, because it really represents, because one of the things, my goals is not to get into the weeds too much. Okay, there we go. Okay, I figured it out. Okay, so I'm not the best with this stuff, but anyways. So again, it's the collaborative approach, the success of evaluating and treating the orofacial pain complex, simple to complex, from a CCTT who's also, and it makes a huge difference because the airway is king airway, and certified in, and I'll explain what neurodevelopmental therapy is. I'll get into that. This is not taught in physical therapy school. They taught you in PT school, in the doctorate program, very basics in joint orthopedics, but nothing beyond that. So, okay, and again, just not to reiterate, but my quest, I started with Janet Travell in 1980 in the Virginia area. She's the one, all those photos with the referred pattern from masseter and temporalis to teeth. Well, I trained with her in DC in the 1980s and 90s when she was still alive, and I had and she opened up my eyes to using needles to help with musculoskeletal pain. So I traveled the world, went to China back in '87, and then again since then I've come across and done so much more. Dry needling was allowed in New Jersey in 2012. We went right into dry needling, and politics pulled out, but it was reinstated in 2023. Again, and the myofunctional therapy, anybody know what myofunctional therapy is? Show of hands. If those of you who don't know, it's the science of tongue strength and tongue control as it relates to the jaw and the mouth and airway, lip control and all that. And again, a lot of pediatric dentists would know about it, and lactation consultants, we work with those kids as well. So one of the key things also in my resume advanced dry needling, I will get into how that science is evolving tremendously, because it's not about the twitch response anymore, which is what Travell was saying in the 1980s and 90s. It's so much more. It involves the parasympathetic nervous system. So to make a story short, I say, oh, I got my needles. I look at my needle. I say, okay, here's my needle. Okay, I'm now gonna mess with your brain in a good way, because the needles affects the brain, the autonomic, the motor cortex, and the parasympathetic, the autonomic, through endorphin stimulation and increasing circulation for blood flow. To allow, and stroke, I'm actually reversing spasticity with stroke. I've had some results of that, even things like heart palpitations. So it really works with the parasympathetic, the autonomic. So anyways, and the other group I'm very much involved with is the International Association for the Study of Pain. And that's because people in pain, they're out of Seattle, international. I go to the World Congress on Pain. People in pain don't move like people without pain. And that's because of the autonomic response. There's reflexes going on. And that's ANS. And then American Academy of Facial Pain is our sponsoring, so that's a medical dental group, and an APTA. So anyways, so I want to get a quick show of hands who you guys are here, who my audience is. I always like to know who are primary dentists in the group. Just to show who do primary. Good. Okay. How about orthodontists? Any orthodontists? Good. Very good. How about a periodontist? Great. Okay. And also endodontists. I know there's a few in here. Good, good, good. Any oral surgeons here? All right. Okay. Yeah. Because I'm sorry. Okay. So again, who is TMD trained? Now, I attended the TMD course at MDA in 1991, 92. So that was with Dr. Hare, who's now the director, and so many others. They're now retired, but 91, 92. So I go back a little ways. Anybody TMD trained here? Yes, Michelle? Yes? No, I know you. And who else? Anybody else? Show of hands. If that's appliances. Do any of you do night guards? Okay, who does night guards? All right. And Michelle, I know you do the airway appliances for sleep apnea. All right. So I guess my one, and I want to save some time because I really want to ask you questions. Because if you have someone with a clicking joint or jaw pain, it's what do you do? Okay, and again, are your parents? Do you see a lot of your patients in that chair with clicking joints? How often? How many clicking joints? All right. I'm sorry.
10 to 20%.
Okay, yeah, but asymptomatic, correct?
Correct.
Asymptomatic until they're not, for the most part. It's complicated. Orofacial pain is very complicated and individually based because of their, okay. So again, do any of you have unresolved jaw or tooth pain, chronic TMD? Have you in your practice? Show of hands. Yeah. Yeah, and I think I was talking, I don't know if you guys know Mitch Davidge, he's the endodontist in Morristown, good colleague. I was talking to Mitch and he says, I've never seen, and everybody knows Mitch, he's had a lot of experience. He says, I've never seen so many cracked teeth in my career. And the pandemic is coming because of other things. Okay, good. So again, jaw, we're not gonna get to the politics of them, but anyways, jaw pain, neck pain, shoulder pain. Do any of you ever, well, you didn't show, there's a connection of neck, jaw, and shoulder pain, as you know. So show of hands who recognizes that, who understands that. Okay, good, glad to hear that. Again, how about non-odontalgic tooth pain? Anybody have some of those? Okay, and that's why I'd love to know how you treat them, what happened to them. Game changer, dry needle, stick a needle in that muscle, gone. Reproduces the tooth pain, don't pull the tooth. That's the quick answer. And again, this is all new stuff, and not all physical therapists are trained in this work. Do you have anybody who has difficulty keeping their mouths open that you have to use a mouth block? Yes? How, is that a lot? My next question, because I'm going to jump ahead a little bit. Do any of you assess their airway or their hyoid position? You do? Because if they're activating their mandibular depressions with their hyoid, they can't keep that. They're co-contracting. So that's what. Okay. How about hyperactive gag reflex? Because I work with people with central sensitization, elevated sympathetic drive. and I get into neurodesensitization, and I teach patients how to desensitize their gag reflex, because it makes them more prone to bracing, right? Sensitive, anxiety, tension, there's a whole emotional side to this. Again, headaches and migraines is, as you know, is very connected, get into that. And then tinnitus, ear pain, that is with a negative ET, I'll get into that as well. And then, you guys see people with dizziness. So hands of dizziness, you guys make the connection with dizziness to the jaw and the head. It's more of a cervical craniovertebral issue, but anyways, okay. So again, as dentists, you probably never attended a course taught by a physical therapist. This is the best opportunity just to get a glimpse of how collaborating with a physical therapist that are TMD trained, not everybody is, and that can elevate the patient care for your patient practice, your practice provides. Again, and I'm hoping that you take from this a different perspective of the patients that's sitting in your chair. So again, we think, again, we evaluate very differently. I am not getting into the crosshairs of what we evaluate and the details of evaluation and treatment. That's for another time. This is more of an overview to have you get a good sense of what we're doing. Our treatment is not only structural. You guys work with teeth, nothing more structural than a tooth. But we also think functionally, okay? And we assess the whole body, especially the cervical spine. And that is where I think you guys are not trained as much in cervical spine. How much? And you show hands. Who feels like they've had adequate cervical spine training? Anybody? Yeah, she's my chiropractor. Colleague, collaborative. I'll introduce you to anyways, so that was the thing, is that, again, the opportunity to gain an understanding about how we assess problems that are, anybody not have patients that you just don't know what to do with, like jaw pain, and you don't know what to do with it. Yeah, show of hands, yeah. And I hope this goal, this program, this presentation will give you a hint of what we do to help you. Collaboration. Okay, and this is the other thing. I always tell my patients, you don't know what you don't know. And you can't see, when you don't know, you don't see what you're supposed to know. So again, and no one tells you what to look for. And you can only see what you know to look for. And if you don't see it, you can't see it. And then the jaw is everything, everywhere, all at once. Meaning, the jaw, well, you have your tongue in there, you got some teeth in there, you gotta breathe, you gotta hold your head up and swallow. It's everything everywhere. Ooh, you cannot separate like an orthopedic. It's about the knee. No. It's about everything everywhere. Because you cannot survive if you can't breathe and swallow and hold your head up. We'll get into that. So it's everything everywhere. So again, the clicking joints. And what I want to say about clicking joints, don't ignore clicking joint, because it's an unbalanced movement. And I'll get into the science of unbalanced movement. Okay, and that again, and it starts, episodic jaw pain, patients who cannot keep their jaw open for dental procedure because they don't know how to open their jaws. They're so contracted. That's basically what happens. Anybody, do you guys assess if patients can get to centric relations? Is it on your radar? Yeah, centric relation. That is a very important thing. Gag reflex is one observation, because if you cannot get them in centric relation, they are very rich in clicking and interdisplaced. And it doesn't take much sometimes to contribute. So they're not going to condylar rotation control. And that's why you can't ignore a clicking joint. And when you tell patients, there's a way that they need to learn that. Balance movement, and it overloads the system. So again, okay, forehead posturing with or without a Dowler's hump. You guys know what a Dowler's hump is? Rear forehead, the fullness at the CT junction. Those people have a syndrome going on with why did their body develop that? And I'll get into that. Okay, headaches and migraine. And the reality is, all of these can happen all at once. These are the conversations I had with some of my dentists who don't know what to do because it's complicated. And again, these are symptoms. What is the root cause? And that's my conversation with, my goal is, again, to give you a better understanding how you can collaborate with a physical therapist and not to be ignored, these symptoms. And again, especially the dizziness, the tinnitus, the ear pain, what's the root cause? And everybody, there is not always one answer because everybody's individual because of the way we learn habits. Nobody has signs or, everybody is unique by the signature, for example, right? Unique. So again, learn about the treatment of TMJ and artificial pain beyond a dentist treatment. Okay, so again, the trismus, why do some patients develop the trismus clicking jaw after dental procedures? And I can explain that too, because it is about the neuromuscular system. And then, again, and I've had so many cases where these situations were ignored and the problem escalated, and I'll get into how we need to intervene, okay? So again, we're board certified in neurodevelopmental treatment as well as granular mind function and in Austin trained. So we're only 6 of us in the state that are board certified in temporomandibular CCTT, but the only ones that's certified in neurodevelopment and all these other things. So again, so we assess not only the symptom and the source of the pain, but get to the root cause, which means assessing the whole body, the entire genetic chain, inclusive of the foot, the pelvis, the spine, neck, jaw, tongue. Now, does anybody know what fascia is? Fascia is not muscle. It's the glue that holds us together. And we did a human dissection, actually, Colin Seni is my associate, wave your hand. Seni, do you remember the anatomy, the human anatomy course on fascia?
Oh, yeah.
And the fascia, do you know that the fascia, it starts at the big toe, and it ends, the deep anterior front line, ends at the base of the tongue. So it is the glue that holds us up, puts us together. It translates from the flexor hallucis longus to the base of the tongue. And when you understand that, that's part of the soft tissue pain, and I'll get into fascia as well. Unless the root cause is identified, okay, the symptoms tend to recur. Okay, and then Pete Dawson, bless his heart, I was very fortunate to be part of his airway training, and I really love what you said. What's the darn root cause? Okay, and is there a better way? And it does take a collaborative team because not everybody has all the tools for the needs of the patient. So again, now this is a very interesting case study. Case study Michelle. Okay, and the purpose of I said is never ignore a clicking joint. She is a 52-year-old woman that was evaluated, referred by her dentist, okay? She had right jaw pain with limited opening to 36 millimeters with a lot of pain. Again, left subluxation and left jaw crepitus. So right jaw pain, left subluxation, okay, and crepitus. But the significant story here with her is her medical history. She had onset of right jaw pain and clicking after finishing orthodontics, which I see a lot at the age of 16. I see a lot of teenagers develop clicking joints in their teens after orthodontics. I don't know more. She had Invisalign in her mid-30s, okay? And her teeth were shifting, but she continued jaw clicking, okay? And she continued asymptomatic, she was managing, but in the summer of 2024, last summer, she had 3 severe episodes of acute open loss on the right side, and she was able to self-mobilize the jaw and close the mouth. However, a week later, she developed incapacitating migraines on the left temporal side. So again, left frontal temporal headaches and migraines lasting from 1 to 3 days, and it was TMJ related. What she ended up doing is, I've got a headache, I'm gonna go to the neurologist. Didn't think about the dentist or the jaw, okay, or the clicking joint. And someone should have mentioned, like her dentist, but didn't say, this could have been a jaw issue, okay? And, okay, so the jaw problem improved, the original jaw problem, but the temporal headaches escalated. She saw the neurologist, she got prescribed Maxalt and beta blockers to manage her headaches. But after she started managing her headaches, the drugs just managed her headaches, didn't get rid of the root cause. Didn't get to the root cause, it managed the symptom. Okay, and so she had recurrence of the right jaw, now recurrence of the right jaw. So again, she had no appliance, and she was a class 2, hold on. Yeah, hold on, let's get back here. How do I go back? Okay, right. Okay, so again, class 2 facial profile. Yeah, so again, genuine orthodontics. So this is the question I had, because when she went the orthodontics to class 1, she was a class 2 facial profile, considering tongue and airway, because she developed clicking joints after her orthodontics. So did the body kind of, and the body will do whatever it takes to breathe and swallow. So that was one of my thoughts. Don't know, okay? But the root cause, what got her out of pain, is that she had tongue weakness, okay? And I'll get into some videos of myofunctional therapy with tongue strengthening with that. She had a craniovertebral craniomandibular dysfunction. She was twisted. The C1 was rotated. She was unable to attain a centric relation, or because she was unable to attain OA neutral. So in other words, let me have you, this VCM dysfunction is very common for clicking joints. So I want you all, I'll leave in here, okay, so find your centric relation, yes, okay? Relaxing that jaw down and back, kind of getting yourself into centric relation. If you bring yourself in forward head, can you attain centric relation? Impossible. That's a mechanical dysfunction. So OA, so now I'm going to get into this because there's a direct functional unit. You cannot move your jaw without stabilizing your skull. Craniovertebral. It's two different joints, but one functional unit. See, so that's called head writing in that whole thing. And then Julia's a new cut. We're going to get into what she does and how we work together. Again, this is so her jaw pain and her clicking joints. We got rid of her clicking joints simply by getting her to address her tongue strength, stop the parafunction, get her into centric relation. But we needed to get her to OA neutral before she could get to centric relation. Layers, onions, layer the puzzle, and then layer by layer by layer, one layer at a time. And so, and she did not need an appliance. She got rid of it. She got rid of her clicking joint, and we could intervene and get rid of her headache. She did it on her own, homework. So it's through the exercises. Okay, so here's another case study, again, from an ignored clicking joint, okay? This is a 43-year-old Casey, 43-year-old woman. I evaluated her just at the end of this year, 24. Okay, she had left greater than right jaw and ear pain, pressure, neck and shoulder pain. Again, left greater than right. She had dizziness. Okay, so the jaw's never alone. It's all many things. And she had right-sided temporal occipital headaches. Okay. Now, what's amazing with her is that when I asked in her interview, her evaluation, in 2021, she had a tubing accident. Okay, and hit her head, neck. She developed neck and shoulder pain and jaw clicking trauma. Okay, 2023, continued clucking, right, since 21, 23. She was hit in the forehead by a soccer ball attending her daughter's soccer game with a whiplash, a little bit of a concussion there. So by 2024, last year, worsening of her jaw clicking, impetus, and pain. So this is before I even saw her. In June of 2024, she was diagnosed with condylar absorption syndrome. This is her. This is her. So condylar absorption, look at that condyle there. And look at this one. Because, again, when the disc falls off the condyle, the disc is part of the cushy part of that. Okay, if it falls off the condyle, the bone is soft and it can really deteriorate. And that's exactly what happened here. See, and I'm not sure if you guys can see the shortness, but the ramus height. And so when I saw her, that's a condylar absorption syndrome. Okay, she was a class 2 facial profile with a craniovertebral dysfunction, C1 rotated right on left, there's the headache. Okay, tongue weakness, tongue to tonsil opening. I look at the tongue strength. So one of the things is you place your tongue to the incisive papilla, have y'all try that, and how far can you open your jaw? You should be able to open to 35. Oh, you're doing it. Good. Let's see. Most of you, let me see, tongue up, see, to spot, open. A lot of you can because you can start isolating your tongue without your hyoids and your tongue tip strength, okay? And that has a lot to do with tongue positioning and strength in the mouth. Okay, I look at that, okay? She could only open to 10. Just imagine that, 10 millimeters. Tongue weakness, she had oral hair function, clenching and bracing. Okay, inclusive of, and that was the other thing too. I want you now to brace your hyoid bones. Brace your hyoid bones. What happens to your mouth? You're bracing your jaw. So people who use their hyoids, open your jaw, and use your hyoids to open your jaw, you see how you're co-contracting your mandibular elevators at the same time. And a lot of people do it invisibly, they don't even know. Actually, a lot. Everybody does. All of my patients do. So these are called movement impairments. They're overworking muscle, movement inefficiency, loss of balance movement. Okay, so again, and with her she had the myofascial dysfunction, myofascial pain, neck and jaw, shoulder pain. It's not random, okay? Cervical whiplash. Patient was unable to isolate. Now with a whiplash, okay, let's talk about cervical anatomy. Okay, so right on the front as your swallow muscles, your hyoids, your gastrix, stylohyoids, sternohyoids. Behind them, okay, is again, and that's to do with swallowing and speech. Okay, tongue is about your swallowing and speech as well, but different. And then behind that, you have cervical muscles, sternocleidomastoid, scalene, respiratory accessory scalene. But deep in that deep anterior triangle behind there is your longus coli. And above it, C1, C2, occiput C1, C2, is your capitis, splenius capitis. So a lot of people cannot find these four muscles. And so you'll go to physical therapy, and guess what happens? Oh yeah, do a chin tuck. Well, they're bracing their throat. Chin tucks are old school because you can't open your throat. So it's old school. So if you go to a therapist, do a chin tuck to fix your hip posture. Not sustainable because you're not balancing and you're not even looking at the ability to breathe and swallow. So again, so chronic neck and chest breathing, again, that was her. She was in that forward head posture, class 2 occlusion, neck and chest breathing, couldn't find her longus coli, so she was way off. Okay, and then she had myofascial tightness of respiratory accessory, which is sternocleidomastoid, upper trapezius, scalenes, to name a few. There's others. Okay, but those are the big ones. So here she is. Now what I want you to see, now you guys won't see this, but you'll see she has a slight crossbite here. And again, it's a slight, she had a crossbite. Not severe, but it was to that loss of condylar height from that condylar absorption syndrome. And she had the right crossbite with limited opening and pain. Okay, so when I did her eval, after 6 sessions, this is her, no pain, corrected crossbite, relaxing her throat, she could fully extend her neck, no whiplash, 6 sessions. You gotta understand the root cause, and she was very happy. Okay, so again, pain is about the brain. No brain, AOP, they talked about it last May. It's not about the nerves, it's not about the tissues, it's not about the muscles, it's not about the spine, the nerve roots. Pain, no brain, no pain. And the pain is where it registers. And then the purpose of pain is survival of self. This is the World Congress on Pain, ISP. In Pain and Movement Science, the survival brain will tolerate pain to prioritize 5 survival priorities. Airway is king. You're gonna do whatever it takes to breathe. If you don't breathe for 3 minutes, guess what happens?
Goodbye.
You're dead. You can't swallow full water for 3 days? Yes?
I just had a question about when you corrected the patient's frostbite.
Yes.
How did you do that as a non-dentist?
Perfect. The answer is you get the tongue in charge of the mouth. Stop the substitution. The tongue up, it disengages the mandibular elevators. It's reflex inhibition. So if you push your tongue up, you can relax the jaw. Push the tongue up to the roof of your mouth, and you can inhibit neuromuscular release of the mandibular elevators, inclusive of masseter temporalis negropterygoid especially, okay? And these people do not open their jaws with their lateral pterygoids. They open their jaws with their hyoids. I'll get into that as well. So if you know, it's muscle substitution. It's always about substitution and muscle overload. And that's a parasympathetic deficiency, not, you can't shut off muscles, okay? So swallowing, did I answer your question? So it starts with the tongue, you move on to airway, because if you have an airway resistance syndrome, UARS, you see, these people cannot even get to centric relation because they cannot get into OA neutral because they can't breathe. So airway is king, and so you need to assess that. Where is that weakness coming from? And it's oftentimes Mallampati scores. I'll get into that. I'm getting ahead of myself.
So you're saying when she's not in occlusion, that you're getting her functionally
Yes.
in the, but when she goes into the occlusion, that's what Dom said, then it affects where the teeth are, but how her mandible's gonna line up with her maxilla.
Right, and that's where collaboration is key with an orthodontist and occlusion. Yeah, absolutely. But our thing is tongue up, teeth apart, lips together.
Okay, great.
You see, we're on the same page on that. I don't do what you guys do. Ah.
You're lucky.
You see, and that's exactly big point. That's why I'm here.
Great,
You guys need to know we exist.
great, I agree.
Yeah, because it's all about function and soft tissue. It's, you know, and that's why I know you have some orthodontists in here because a lot of, and I hope I have some time at the end to get your intake about when people are class 2 facial profile, class 2 occlusion, but they get pushed into class 1 orthodontics, what happens? And again, and you know, if you're respecting airway and you're respecting soft tissue, and again, the tongue is an easy one, you can train it. But I'd love to get your perspective on that. We need to have that discussion, and I'd love to do that, and what's the best way to go. So again, the purpose again, and oh yeah, there's more, seeing. You're all looking at me right now, okay? Put your hand on the back of your neck. You're using your neck muscles to hold. You don't even know you're doing that. Okay? But that's not somatic. That's not voluntary. It's autonomic. Head writing reflex is autonomic. Looking up and turning is somatic. You see? And how you do that has to do with habit. Okay, so to see, head writing is a reflex. Because you can't hold your head up, you can't survive in the wild. And then this thing nobody feels, gravity. Anybody been to outer space? Don't know what it's like without gravity, and you've never known it. So your perception and reality, this is why I bring that up, okay? Again, the autonomic, so your perception and your reality is not the same. Just because you don't feel it, your brain is blind to that. So again, our assessment includes screening of all these functional priorities. Again, and just as quick review, there's the parasympathetic, okay, fight, and then the sympathetic. Rest and repair, rest and digest, rest and sleep, versus fight, flight, freeze, okay? It's one knob, one or the other. It's either, and then the other thing is the somatic. That's the voluntary brain. So let's talk about how you feel this yourself. I want y'all to put your hands behind your neck. Now, okay, and sit up straight in your chair because you won't feel it otherwise. Okay, so all I want you to do now is put your hand behind your neck. Okay, and now just do this. Collapse your chest. What do you guys feel under your fingers at your base of your skull? Feel them working?
Tension.
Yes, they activate. They activate. Now, that is not somatic. That's autonomic, head writing reflex. Look up now. That's somatic. But head writing is automatic. And understand, and that's the intermingle. And that's where the reflexes are so key. Okay? So again, sympathetic, fight, flight, freeze, rest and repair, rest and digest. And then, yeah, and this is the game changer, these meters, because it's the first way I can mess with your brain in a good way. Pain relief. Okay, so again, it accesses the parasympathetic. So again, holding your head up and looking, one is automatic, one is voluntary. And again, let's talk about what perception and reality. I talked about gravity. Okay, our brains are blind to reflexes. Think about blinking. You're blinking. It's about survival. You're also breathing. It's a breathing reflex. Anybody not breathe right now? Say, thinking about perception. You're totally blind until you pay attention and know that such a world exists. It's just human nature, okay? And then this thing with gravity, okay? So again, attention and focus executes the executive function brain prefrontal cortex and can make you aware of these habits and reflexes. Now, let's talk about habits. Our signature is a habit, right? Unique to us. I want you all to do something for me. I want you all to cross your arms. Just cross your arms. How do you guys look at your arms? Okay, so Adam, you're crossing right in front of left. Let's see. Okay, you're doing left in front of right. Let me see. Okay, right. Okay, now uncross your arms. Don't think about it. Cross your arms again. You're gonna do the same way. Now cross your arms the other way.
I have to think about it.
Okay, someone's working it. You're working it. You're working it. It's weird. Okay, so just cross your arms normal, how you normally cross it. There we go. Now cross your arms the other way. You have to think about it. And that's, again, you're totally unaware that I want you to interlace your fingers. It's to keep, interlace your fingers. Now, I will demonstrate here. Me, I interlace my hands this way. Woo, right in front of left. Some of you may do left in front of right. Okay? Now, try that. Go from your habit and interlace your hands the other way. You feel like holding someone else's hand? Isn't that crazy? Habit. We're creatures of habit and we have no idea. Now, if the habits are unbalanced, that's where the cranial-mandibular habit becomes escalation. Like that jaw, clicking movements. Is that all making sense? Yes, Kenneth?
I will say it's a habit for people to clench.
It is a habit for people to clench. Posture is a habit. And again, especially if you have trauma, forward head posture, it's very much. So again, humans, I just want to explain that these things occur. And it's on our assessment tool. you guys, but I hope you guys will start paying attention to that next time you see your patients in that chair. Because it does have a lot to do with what you do inside their mouths. Okay? Again, so the NS, so airway is where they overlap. The reflexes, the swallowing, the chewing, talking, head writing. Head writing is both craniomandibular, craniovertebral. Let's talk about that. Okay, so put your hands on your neck again. Okay, now, let's talk about, now bring your jaw forward. Can you feel your neck? See how your neck comes forward? See, you contract your neck. Okay, let's talk about that whole condition. Okay, and you were just doing it a while. Okay, let me bring my jaw forward. You see? You ever see people who open their jaws like this?
Yeah.
The tail wags the dog. Headaches, neck pain, jaw pain, clicking noise. And then you add a little bit of airway, you know, radiculopathies, scalenes, reflexes. You see how it all kind of works? And you don't see it until you see it. So vision, you see, so vision is important to orient, eyes horizontal, nose vertical. Okay, so again, the brain learns by feeling, by doing. Anybody ever learn how to ride a bike not being on the bike? How do you learn a sport? You do it. You learn how it feels. That's called proprioception. Okay? And again, I don't want to get into the weeds too much, but the other thing is that you don't play soccer to be better lacrosse player or football player. Again, it's exercise specific. And that's kind of what I learned about the neurodevelopmental model, you see how the brain learns movement. From infancy, because as an infant, I think I'm coming on to that, okay? And the thing is that, again, how do you get better? I tell my patients, I'm the coach, you're the healer. Take the drugs, well, you're managing your symptom. Well, what's the root cause? And really kind of, and what I want to say, and this is why I've had a lot of requests by my dentist, these handouts here, referring to therapy, patients don't show up, who should you refer? I've had so many questions. Carol, I just saw my patient, you helped her, what'd you do? Who should I see? They kept asking. So I'm giving you the background, which is why I talked to us, okay, well, I gotta get into the basics of why we evaluate what we evaluate. I'm not getting into the evaluation, but I'm explaining why. Got that? And you guys never went to PT school, so you wouldn't know. Okay, so again, how do you get better? You practice neuromuscular control. Okay, so those of you who interlace your fingers one way, separate your hands. Now do it the opposite way and do it 5 times. It gets easy. Look at you. Look how fast you're going. Yes. You see, but guess what? I have motor morons sometimes. Don't have a clue. Can't feel it. Motor morons, can't feel it. And I just had someone, anybody know Greg Jacobs, oral surgeon? He just sent me someone. This man could open to 13 millimeters of opening. And he was like, okay? And I was teaching, place your tongue, relax the tongue. Motor, getting into awareness. We opened him up, first visit, I only saw him the once so far. He opened to 23 millimeters at the end of the visit. But I showed him, get your tongue to relax the jaw. Had no clue. I said, well, and all I say is, you did it, but try to focus on how it feels. Motor morons, you can't do it, okay? You keep what you do. Success is a decision, and mindset is everything. So healing is about the patient, not you. Good prayer. Okay, so again, the brain's little movement, purposeful movement from primitive reflex at birth to adulthood. Humans develop from these reflexes, the INS, to control movement, somatic, voluntary. So at 3 months, the moral reflex, okay, the moral reflex is a sudden, becomes the pain reflex. They get into this whole reflex as an adult, like a newborn, the moral reflex, a loud noise. motor reflex is, yeah, you drop them. Startle reflex is surprise them, loud noises, drop their heads. That's a stress reflex. Suck swallow reflex. You see, these infants don't have control. It's all reflex. Suck swallow, tongue control, and that's why we're having conversations about tongue tie as pediatricians. Some kids can't even nurse, and that's where tongue tie is critical. And I'm not sure why it's missed by pediatricians. Again, the asymmetric neck reflexes, head control, holding. The asymmetric ATNR has to do with eye-hand coordination and head control. You know, they kind of go in, and then the grasp reflex gets to hand. So those are just real basic stuff with that. And there are, again, the neurodevelopmental. And I spent a lot of my early career integrating this. And people with stroke rehab need this reflexes to get the control as well. But the game changing with this stuff with spasticity is the needle again. Okay, so again, airway involves the cervical spine. Okay, so again, PT training TMD and airway, not just TMJ, can accurately assess because you need to key into the autonomic airway is king, the reflexes. A lot of physical therapists are into this world, herniated discs, posture, all this, but they miss the airway and the reflexes. So very few therapists are trained in both, and so that's where sometimes, and I've had conversations, well, they went to their physical therapist, they knew this physical therapist, they worked with that therapist, but that therapist did not have the skills, right, Michelle? Our conversations, to address the issue. Because not all therapists have the same information. As you know, not all dentists as well. So it's all the same. Okay, so be an educated dentist and educate your patients. So again, and there's a tremendous need for this. I get requests by PTs to teach a course. I've been in the clinic. I'm not a teacher, and this is definitely not my comfort zone issue. But I need to be teaching this. I just know too much to help people. I can't walk away. And again, soft tissue pain. Now this is Travell's work. Muscle pain is invisible through MRI, medical workup. Even EMGs are negative, okay, neurologic. Again, it is not a structure-based model, so definitely difficult to measure, but muscles and taut muscles affects function, and it involves the autonomic and the somatic as well with elevated sympathetic drive, scaling tightness, for example. Neck breathing is one of them. And this is, you guys have seen this is Janet Travell, and referred to teeth, referred to eye, ocular motor. Actually, Nancy, you're up here. Oh, yep, hold on now, let me go back. This, let me see, oh, let me go back.
I noticed right away when she started showing this.
Where did it go? On the back, how do I go back? Oh, this one, okay, there we go, yeah. So, okay, so, yeah, let me go back there. All right, so, I have a patient here, Nancy. She's here. You see your photo up there?
I noticed the spots that where it bothers me on your slide, yeah.
And what, can you share everybody?
Sure, do you want me to
Why
get up or
she's
just?
here? Yeah, get up and you can just, Nancy is a patient, she's so driven
Yeah, so Carol told me she was coming, and I'm like, I gotta come and listen to her speech, because she'll teach me things as we go along, but I don't always remember it. I try to write it down and then look it up later and stuff. But a lot of all these things were the problems I've been having. So I've been having issues since I'm in my 20s, and now I'm in my 60s. You know, early.
muscle memory.
So the problem was that it's complicated, as Carol said. We'll peel the onion. And so I was having jaw pain, I was having head pain, neck pain, pain behind my eye, and I would go to the dentist, the neurologist, the allergist, ENT. Yeah, I think I had a list here of who I went to, but I went to the different types of dentists and stuff. And so and I would also go to physical therapy. I've also gone for chiropractic and done these things over the years. and I've gotten relief, but then it comes back. And then I do the rounds all again through everybody to see, you know, if I can get some results, and it helps, and then it comes back again. So in October, I was referred to Carol after I went to the ENT, the neurologist, the allergist, the whole rounds again this year. And there could be some things, but they weren't quite able to say it was definitely a tooth, or it was definitely, you know, something else with the neurology. So when Carol was doing the dry needling, we were able to reproduce some of this pain. And by being able to, I could feel when she was doing the needle, it releasing in the muscles. And so that definitely is a help, and it also shows that it has to do with the muscle and, you know, the nerves in that area. And so a lot of this is very helpful for me, so I can at least start addressing it. And Carol's been giving me exercises to do, which is helping.
And thank you, Nancy. It's complicated. There's so many. Keep your feelings, you see. But is there a way? Absolutely. This is all reversible pain in my opinion. So thank you, Nancy, and thank you for coming and sharing. See, so you guys all know this. I'm going to skip ahead. This is a big one, of course, the upper trapezius and the suboccipitals. All right. So again, so why don't people? Anybody have an appliance that didn't help them? They spit it out for their jaw pain. Okay. Well, the reason for that is because they cannot breathe. It takes space in their mouth. Airways they cannot tolerate. So the survival brain, they spit it out in their sleep, or they can't tolerate while they're awake. Okay, and again, it involves the soft tissue, the muscles, oropharyngeal weakness, and tongue weakness, all of that. It's all, again, aspects to consider for airway. And I'm not sure if you guys look at this or not, but you can just glance a little bit. But the facial profile, are they a class 1, class 2, class 3? I'll have photos of what facial profile. Cervical spine position is a huge indicator. Forehead posturing is a way to improve your airway, okay? So is tongue position, tongue down, tongue thrusting, tongue weakness, low muscle tone, oropharyngeal tightness and weakness, Mallampati scores. And this, the oropharyngeal fold, the gag reflex. Can't, okay? And then an elevated hyoid bone. Who looks at the hyoid bone? You see, and that is a strategy to open up the airway. Forehead posture, of course, Elder's hump, and then the tori, okay? It can be any combination and or all. It really, every patient is an individual. So again, explain the appliances do not work. Airways King, ANS, and the invisible protective airway. You can only attain centric relation in OA neutral. But if you can't breathe, you can't get there. So I like this. This is from the Dawson Academy. A great example of class 1 versus class 2. And the thing that I want to emphasize here is, again, oropharyngeal space here, the position of the mandible. Okay, lots of space, no space. You see, she's deficient. There's another one, the angle of the mandible. You see, the lower the angle, the better, more space, oropharynx to breathe. Okay, now this is an interesting story. Here it is, forehead posturing. Look how young she is, okay? And look at her nose to her toes. Her nose is in front of her toes. I know you guys are all eating, but if y'all want to stand up and get your nose in front of your toes, you realize how hard you're working to stand up there. Muscle overload, and you don't even know you're doing it. And in her case, and now she is, difficulty breathing in neutral neck position. And look at her CT junction there. And one more photo, big photo. Look at her tongue tie. That's not random. So my question is, next time you have that person in that chair, just take a look at their facial profile, their posture, nose in front of toes, forehead posturing. And then the other thing is, do you guys assess oropharyngeal Mallampati scores? Tongue base. And if you're not, you should be taking a quick look at that. And guess what? Your gag reflex person cannot drop your tongue. You see? And And all I'm asking tonight is, oh yes, the next time tomorrow, am I gonna look at these things? And all I'm asking is that, okay? So forehead posturing and airway. This is in Sharu Zagi. I trained with him. He's out of California, ENT, airway tongue guy. And these are his, see that airway versus restricted airway, open airway. Again, correcting, cervical extension, head posture. And these people need to extend their necks. Sharu's also talked about the tongue. Okay, again, breathe institute, tongue restriction, and then opening the airway, being able to bring that tongue up and forward after lingual frenectomy. Okay, one thing I'm now understanding, though no lingual frenectomy, if there is a moderate to severe sleep apnea, you're gonna make them worse. Okay, so again, real quickly, patients in pain do not move like people without pain. And again, and you can kind of start that. The purpose of pain is protective and survival based, tissue damage, broken. Yeah, so that's the other thing too. If you go ahead and walk down the street and you strain your ankle, okay, you start limping, right? That's that reflex. Okay, tissue damage, danger. Okay, there's tissue damage or danger. Okay, and there's an emotional pain, part of pain now. The protective reflex, muscles co-contract. Okay, or they don't work. That's what they do. So pain impacts motor control, not somatically, autonomically as a protective reflex. So again, muscles shut off. So again, they do it to protect and not cause more damage. Don't walk on the broken bone. That's why we limp after a simple ankle sprain. Again, the danger is burns and pressure. Okay, and then the emotional side is fight, flight, freeze, and anxiety. So pain and movement science, pain changes the ANS into increased sympathetic tone, resulting in loss of muscle coordination and strength. This contributes to muscle overload in those photos from Travell. Okay, so again, the importance of balanced movement, TMJ conduit rotation, no clicking, no popping. So I hope this gives you an idea about never ignoring a clicking joint, because they're probably not in OAC craniovertebral mandibular neutral position. Positional strength. Oh yeah, so this is a very good one too. Strength tension curve. I want you all to make a fist in neutral wrist. Give it all you got. Okay, and you can feel what your strength is. Okay, now relax that fist. Okay, and hold your arm up because you'll feel it more. All I want you to do is to bend your wrist. One thing, bend that wrist. Now you're no longer in wrist neutral. Now in that bent wrist position, make a fist. What happens? What do you feel?
Weak.
You feel the weakness. You're weaker, right? You feel the strain in the joint. Okay, keep going. What else do you feel more?
Forearm tension.
Works harder, right? You're working harder here for less. Okay, keep going. What else starts to happen? Think about your biceps. Think about your shoulder. It's called muscle substitution. That is a reflex, but it's all positional reflex. You go into substitution. So let's go back now, make your fist. It all goes away. Poof. Neutral joint. It all goes away. Poof. Stop chasing symptoms. Tight muscles. You see, smarter, not harder. Movement efficiency. The problem is that we develop suboptimal habits that puts us out of balance, and we're blind to this process. So I need Adam, can you be my volunteer? I know you're
Sure.
eating.
No
Okay,
problem.
because the next part is strength tension term, and that we develop suboptimal patterns. Absolutely. Okay, it proves strength tension curves, and I'm gonna go, yeah. Okay, so the importance of neutral joint. Okay, so now what I'm gonna do is set straight. There we go. No. Okay, I want you to lift your right arm up. Good, that's his range, and bring arm down. Now you're gonna do one thing. Slouch. Now lift your right arm up. Can you see how he can't get up there? Come back down. Try it again. Go as hard as you can.
Slouched?
No, slouch. Yes, lift your arm up. Come on now. Come on. Okay. What do you feel?
Tension.
Tension. Now let's fix it. Straighten up. Poof. Now lift your arm up. Yay! You got it. You see? More. Arms out. Okay. Nice and tall. Stretch. Good. Push your hand into my hand. Push. Give me a gut. Now just slouch. Okay, okay, now hold there. Now push into my hand. Come on, Adam, get your strength up. What's going on? You see? Now, fix up, grow up. I tell my patient, you gotta grow up. I'm out. It's about time you grow up. Push. There you go. Oh, you got it. Good. All right, let's talk about the neck. Nice and tall. Woo. Look to the left and look to the right. Good. Now slouch. Look straight ahead. Slouch. Now look to the left. See where he's losing it? Look to the right. You see? He's getting to there. Now straighten up again. Now look to the right. That's left. See how he's going further? Because in neutral joint, your movement is more efficient. Thank you. All right? Again. It's called moving smarter, not harder. Okay? So if you're in the habit, so that's why I'm saying next time you see a forward head person, okay, think about what I'm talking about here, okay? Pain and movement. Again, so again, bilateral condylar rotation control to balance. Okay, hold on, I went back there, hold on. Okay, oh, what's going on? Let's see here. Okay, good. So again, the importance of neutral joint, okay? The agonist, antagonist, synergistic. Oh yeah, one more thing, Adam, come over here, I'll show you. Okay, so that, one thing I want you to do, okay, hold your breastbone up, bring your arm out. Okay, now I want you to tell the audience what you're feeling over here when I push your hand up. Push. Can you feel this working?
Yes.
Okay, now slump. Okay, the more you slump, now push into my hand. You feel this working?
Trying.
Trying, not the same. What do you feel working here?
Yep.
Harder. All right, this is weak. He's making up. This is again voluntary but autonomic. Your body substitutes. That's why you should never ignore a clicking joint because it leads to other problems. So Adam, you develop a shoulder problem if you work like this all the time. Now you guys as dentists have an occupational hazard. Oh yeah, let's go there. Ah, nice and tall. Okay, here we go. Nice and tall. Nice and tall. Push into my hand. This is another one. He's crazy. Push, 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 push. That's his. He's getting better. He's getting stronger. Okay, now just turn towards me. Keep your knees there. Now I just rotated his spine. He's now straight here, but twisted. Push into my hand. He's twisted. Get him back to straight. Stable. Be stable. Here you are. You see? It's positional weakness. And when you're twisted, you're not as strong. It's like that wrist. You see? So, and that's what we call function. That's called normal function. You see? And that's the somatic with the reflexes, positional strength. So is that making sense? So moving smarter, not harder. Stabilization equals movement efficiency. Balancing the movement. So that's the strength tension curve, okay? So you're out of neutral, you're strongest in mid-range, and then you lose it again. So again, oh yeah, let's do about this, edge to edge. You guys do appliances, right? Okay, I want you to plank. Now bring your teeth edge to edge. You are using that strengthened curve, you're now no longer joint neutral to weaken the punch. You didn't know you did that, right? Or maybe you did. But it's crazy stuff. But it's how, when I read this, it's like, oh yeah, that makes sense. But it's because of this issue. Thanks, Adam. Positional weakness, okay? So you can only, again, I go back to centric relation and only neutral. So again, patients that you provide, yeah, so that's another thing, okay, that I was, when I'm putting that. How about some of you who do tooth restoration, bite restorations, but you don't put them in OA neutral. Okay, so bring your teeth together. Okay, bring your head forward, touch your teeth. Bring your tongue back, look up. Your bite changes every which way in head position. So if you're doing an occlusion, I've seen this, patients come to me, yeah, bite, change that bite over there. Okay, now they tell you, how's it feel? I bite over there. And then they go home, that feels pretty good. And they totally flare up. I've seen that happen as patients, okay? So again, do you have patients that you provided tooth restoration, crown, implants, that you struggle to balance their bite, and they come back and their bite's still wrong? You never looked at their head, their neck. You see that? So again, patients' ability to sustain centric relation. Why can't they, with support? The ANS head writing reflex and the airway are invisible reasons. They must be able to retain OA neutral in order to balance bite. Okay? And again, we're gonna get into the stuff, the TMD cranial-mandibular connection, the importance of balanced movement. Again, work together. So again, it's imperceivable until you bring your jaw forward, you feel your neck forward. So feel your neck, and then bring your jaw forward. You feel your neck working. You see? And you don't even feel, you have to get your fingers in. Does anybody not feel it? Because if you're not feeling it, you're already in forward head, and then you're getting more load. It's not imperceivable. But people are in somewhat neutral position, okay? So perception versus reality. Okay, so again, that's the whole thing, and this is again, just a review, this is C1, this is C2, there's the odontal process, this is the cranium, C1, C2, and these should all be fairly level and equal in distance, okay? So again, TMG, cranium, okay, the reason people cannot attain set is because they're stuck in posterior rotated cranium, okay, for different reasons, and cannot attain OA neutral. This can be mechanical or neuromuscular, like habit. So you gotta figure it out, okay? And then again, people with restricted airway will posture and forward head to breathe. This is especially so with mouth, neck, and chest breathers and tongue down posturing. People with UARS will tend to have an elevated hyoid bone again, and there's weakness. They cannot tolerate activate longus coli and lead to substitution. So consider your head position when you equilibrate your patient's bite for bite equilibration, appliances, but especially routine dental work, implants and fillers. So here's my forward head. See, that's forward head. Look at him, forward head. Young. Okay, can you see that? Okay, so now look at this. Look at class 2 occlusion. I mean, these guys both had chronic neck pain. You see? So those are extreme cases of class 2, of course. But you can kind of see, again, and again, what's a posterior rotated? Why are they in posterior rotated cranium? I want y'all to feel that. Stick your chin forward and breathe. It's easy. Versus here. See the resistance? There's a little more resistance, okay? Again, so forward head posturing opens the airway, okay? And it also elevates the hyoid bone. It will also do that. So tongue tie, tongue weakness, inability to isolate the tongue from the hyoids, like that young girl with the 2 dimples in her tongue. Oropharyngeal tightness, neck malapati, and then jaw opening. Again, if you use your jaw, not your hyoids. Again, and again, how do they open their jaw if they do? Okay, open your jaw. That's not good. Okay, again, and jaw opening, substituting hyoids, co-contraction. People who have difficulty keeping their mouths open have this syndrome. They need a bite block. Okay, jaw fatigue. Okay, especially with root canals. Okay, I've treated many patients with trismus and jaw pain after dental procedures. It happens, okay? Again, it's hypersensitive gag reflex. They're in fight, flight, freeze, tension, okay? Neck and chest breathing. Okay, so let's talk about hyperventilation here. Okay, so hyperventilation, okay, I want you all, okay, to take a belly breath, and you're gonna go ahead and hum, slow and deep, as slow as you can. Now, what I'm gonna do is I'm gonna start my timer, and then when you're done with your humming, raise your hand, and I'll give you your time. Okay, so everybody? And I do test this, my patient. Belly breath, and I'll start hum. And when you stop humming, raise your hand. 10 seconds. So that's good. Yeah, so again, I have people that do, that's it, that can just be, they're in elevated sympathetic drive. Yeah, I guess the wine helps too, doesn't it? That's right, there's no, I agree. Okay, so again, under 10 seconds, moderate hyperventilation. It is a measure of fight, flight, freeze is what I look at. It's not an absolute, but it's a screening. Again, over 23-second out-breath humming is normal. The other thing also, breathing in is sympathetic. Breathing out, anybody do yoga breathing? Okay, meditative breathing. How about the out-breath? It's right there. Breathing out is parasympathetic. Roger Price, he's an Australian I trained with. So that gives you another thing that we look at as well. So again, Cote posture, look at her cervical spine. Look at this. Severe. And she's young. You see, but this is a symptom, all right? Let's go to this one. Look how young she is. See this, the lumps? So these guys, what does a dowager's hum tell us, okay? Elevated hyoid bone, super high muscle tightness, severe paraspinal tightness at the CT junction, tendency to neck and chest breathe. They hold their tongues down, especially if they're also mouth breathers, and unable to take circulation, and the jaw goes into early condylar translation. Okay, so again, this jaw opening. So that's the whole thing, and that was just some higher substitution for lateral pterygoids, unable to activate longus coli capitis. And then there's the upper airway. One of the tests I look at, I'm not getting into this, can they put their tongue to their tonsils, head nod, tongue to tonsil, head nod, and breathe? And a lot of them cannot, they have airway. So again, now this is severe craniovertebral instability. So I want to introduce Julia Radwanski. She's a NUCA chiropractor. And if you want to introduce yourself, I invited her because you guys need to know about her because of this craniomandibular craniovertebral insufficiency. Please let them know. She's on my team too.
So big picture, what we look at is if you've had an accident or an injury, whiplash, concussion, or you've ever been a kid that's played a sport or learned how to walk, you've most likely had a head injury, right? What happens with a head injury, if the head and neck shift out of place, it actually jams into that position. Your brain stem sits right there. So when you look at exactly what Carol's talking about, right at where the skull, the occiput meets C1, C2, there's actually a very important neurological junction right there. So that's why, I mean, you'll see it in your patients, probably in some of you as well, this head tilt where it's like in every picture, their head is crooked, or their posture, their head is crooked. Some people it's visible, this like 4 or 5 degrees, other people it's not visible at all, but it's still there. Those are the patients that have seen chiropractors, seen physical therapists, and not gotten this like long-term results, right? Where it's like, hey, it helped and then it came back. It helped and then it came back. Clearly you're not getting to the root cause. So a lot of what Carol and I do overlap, where we have many patients that we share where it's like, we're looking at the structure of if your head and neck are jammed in the wrong position, we take very precise x-rays before, then we take the same exact images immediately after a correction. We actually take x-rays throughout the correction process. When you think about chiropractic, what do you think about?
Boom, boom.
Boom, boom, boom. Do you want to know the last time we did that? Chiropractic school, right? I graduated and have not cracked another person's neck ever again, right? It works for some people. It's not precise. It's not exactly what the body needs. When you can perform a precise correction, it's gentle. Basically feels like the amount of pressure that someone's taking your pulse, but it's a very specific, very calculated position, measurable on x-rays before and after. So we see an immediate change from this type of posture. If this is twisted, the rest of your body twists to compensate. We see an immediate change of getting this back in the right place, gets this back in the right place. So Carol and I have actually never talked about this component. I use a very similar example with the bite. Go ahead and tap your teeth together just where you're sitting now. Notice where your teeth are touching. Tip your head to the left, tap. Tip your head to the right, tap. right? Completely changes your
Oh, yeah.
bite as well.
Yeah.
So we see this, you know, in fact, I'll see dentists who have done a good job with the bite and they've adapted the patient's bite. Then we get them back in the correct alignment and all of a sudden now their teeth feel off.
Yes.
And it's because their dentist did a good job, but they did a good job when the patient was in the wrong position, right? And it's like, hey, my teeth aren't touching correctly. They restore that. And then when we actually correct it, because they're coming in for other problems, now all of a sudden the restored teeth are actually in the wrong position, right? And so we're looking at it from the structural side, and then physical therapy is looking at it from, hey, what are the muscles doing? And so the question becomes, when do you go to who, right? And that's for us to really decide, right? So it's not your job to know exactly when they need which professional. Send them over, and if they need structural care, Carol knows me, right? If you see their head physically in this position, probably a good idea to send them to
And
me,
you
but yeah.
tell where your location, and
Yes.
how many of you are in the state? Not many.
Yeah, so there are 300 NUCA doctors in the world. 30 of them are board certified. I am one of them. So I have patients from Kentucky that fly in. I have patients from Massachusetts that come down, Pennsylvania that come in.
Africa.
Yeah, Uganda, yeah. So, and then I sent that one to Carol as well. No pressure, right? I was like, hey, I'm flying here from Uganda for this. And I was like, are you sure you don't want to see my colleague? He's over here, you know? But no. So what we do is very, very, very specialized. It's the correction process is what board certifies you. So it's not like, hey, I've been doing this for X number of years, or I put in X number of hours. It's the ability to take a patient's misalignment, correct it on a very reproducible x-ray, and show the amount of correction you're able to get and then sustain over time. So I'm right on the border of Bridgewater and Branchburg, so if any of you are familiar with this area, like the Wegmans in Bridgewater, we're a couple miles down from that. So not far from this central location. I would say at least 70% of my patients drive 45 minutes or more. So it's just, there's no one who does it.
And Julia has x-ray eyes.
Yes.
She gets the x-rays.
Yeah.
And you have
I don't have
cards,
experience.
you have cards?
I do have cards. I almost forgot them. I literally was just like, I'm coming, and then I was like, I better grab
But
some of those.
my point
Yeah.
is collaboration.
Yeah.
I don't do what you guys do.
Yeah.
I don't do what she does either.
Yeah,
It's the needs of the patient that drives it,
yeah,
you see.
yeah.
So I have a patient that she's had, I don't know, she's been with me for 7 years, and 7 years she's been in just horrible pain.
Yeah.
Like,
Yeah.
I mean, she went to Rutgers, she had unnecessary root canals done, she's seen every specialist, and now she's seeing a NUCA
Okay.
chiropractor.
Yeah.
And she told me, she's like, it's amazing. It was voodoo. She touched me, or he touched me,
Yeah.
and I feel better.
Yeah.
So fascinating. There's
Yeah.
absolutely no information about you guys online.
Yeah.
My brother-in-law is a spine specialist, and he was, I had a C1, C2 fracture. So he was like, don't ever go to them.
Yeah.
Absolutely, don't let them touch you. So he is completely uninformed about you.
Right.
But treating this patient, like, her bite, she touches, I think, on about 4 spots in her mouth.
Yeah.
And, I mean, like, we've gone over that, a lot of this has been, you know, her musculature. It's really not her bite that we're trying to establish.
Stability.
She's very unstable. I mean, she's gone through multiple different orthos by now,
Yeah.
surgeons. And this is what's helping her, but what I'm driving to ask is, how do I help her now? Because she's with you, with NUCA
Yeah.
chiropractor, and she's having some improvement, definitely significant improvement, but, it's not stable.
Okay.
Right.
And like, where do I go with treating her
You
as far
need
as
to
dental?
isolate. This woman is probably substituting hyoids, digastric, scaling.
She's done through
tongue.
speech therapy by now.
But it's
So,
not myofunctional.
Here's what I will
we're
say.
doing.
I have been under NUCA care, what I do, for almost 15 years now. I never held my alignment well. Like, I've seen the best in the country. I go to the conferences, I teach at the conferences, I can get adjusted by anyone I want. I never stabilized well. I found out about Carol, I was like, I need that, right? So I'm a patient of Carol's. That's how we, like, and she was like, man, you are messed up. Like, it's like, hey, someone can get you in the right position, which is wildly important. Like, we see life-changing results with what we do, but if the musculature isn't right, so for me, it's that exact, my hyoid was so tight. She's like, look, you can't even move your hyoid. And I was like, I've never even tried, right? So I had all of these, like, exactly what Carol's talking
You don't
about.
know what you don't know.
Exactly. So if someone has developed these patterns where they're locking their musculature in place, then all that tension creates an immense amount of tension at the suboccipital junction. So,
Because of that.
yep. So it really is this beauty, and they're busy, you know, I refer patients to them, I'm like, you're gonna have to wait. And it's the same with us, we're usually several weeks out to get an appointment because there's so few people who do this. But I've had I had a patient that I just referred, I was like, you're gonna have to wait. And they were like, can I see someone else instead? And I was like, no, honestly, no. You know, it's like you really need both. You need to get it in the right position structurally. If it's jammed in the wrong position, then that's a problem. But then you need to get the muscles to relax. And for some people, just getting them in the right position, everything relaxes on their own. For other patients, myself included, we just develop this locked in
And let me say
pattern.
this too, the art of the science is that even myofascial release is too aggressive for some of these. So I actually have to use dry needling.
Yeah,
It's less aggressive, but it's their brain that does it.
Yeah.
It's all about strategy and the wisdom to know.
yeah.
So very few therapists, PTs understand the science of dry needling. I want to get to that.
Question over there, you have.
Yes.
Yeah, along those lines where, you know, when a patient has to wait for an appointment and you're like, can I go to somebody else? When I refer, I always get, well, can I just go to a PT who takes my insurance?
Yes.
Right?
Oh.
Yeah.
What is the best way to address that? Because it's a hindrance and we need to be able to vocalize what, you know, what should we say?
Well, Michelle, I want to answer that. You
Yeah.
can,
No, I already
Yeah.
asked you this,
My,
Carol.
I'm sorry?
I already asked you this, but we need
It's
our
education.
conversation to
Can
get
we
there.
do it in five visits? Actually, what would you want to say, Julia?
Yeah.
What would you say? What's your take?
So,
You know?
honestly, often I'll be like, have you tried that? Right? Most people have. Most people have tried what's in their insurance network. Did it work? No, clearly, or they wouldn't be asking you about it, right? If it works, if someone in the insurance network where they kind of do their typical, like, hey, we do regular PT, we see 5 patients at a time, we give you chin tucks, we give you this basic exercise, if that works, go ahead, right? So I tell people, like, hey, she really gets to the root cause, it's worth it. If you want to try someone in your insurance network, go ahead, right? Like, I don't need to be a salesperson because if it works, whatever's in their insurance network, try it, right? Now, I'll have conversations with patients, like you may have several co-pays, so you're still gonna have an out-of-pocket cost, but mostly as a referrer, I would say, hey, just call their office, go to their website, look at it. Like in our office, what we do is so different. We always start with a complimentary consultation because I don't want you as a dentist to have to sell them on Nuka Care. You're like, I only know this much. I just say, hey, she's really good. Just do a consult. I refer people out all the time where I'm like, hey, try physical therapy first. Try someone in insurance network. Have you tried A, B, C, or D? Like, if that doesn't work, then call back. And I tell them, honestly, I'm like, I hope I don't see you again. Like, you're a pleasure to meet with. I hope that works for you. Because if it does, fantastic. And if it's not, now that fills my practice with like the most complex patients, right? And so I said to my husband once, I was like, I wish I just had someone with just neck pain, right? Like that would be nice. And that's what you think of when you think of chiropractic, but we see these neurological vertigo, dizziness. I see a lot with trigeminal neuralgia. I see a lot with complex migraine patterns and tension headaches that overlap, where it's like both tension headaches and migraines, right? So it's the same with both of us, and I would say you kind of put the onus on us to have to do the selling and say, hey, if you want to try that, go ahead. Like, it's not our job to force someone into what's best for them. You can lead a horse to water, you can't make them drink.
Yeah, that's true.
Could I add something?
Yeah.
Yes.
So having gone to doing the traditional route and not having it not work, for me, it's worth the extra money to take care of myself because you waste money on a lot of other stuff. why not spend it on yourself and feeling better?
That's right. Yeah, because you're worth it.
Yes, exactly.
So how do you do actually the adjustments, like?
Yeah,
I'm
so I'm happy to answer that after. So that way I was gonna say, I'm sure you have more,
Yeah,
right?
so-
Yeah,
I do
so I
have a
can
little
talk
more.
Nuka after, but it's very precise and very detailed, but I'll show you, yeah.
Yeah, it's really, there really is a lot to it, and again, I just want to introduce, okay, so again, headaches, neuroanatomy, suboccipital neuralgia. I'm gonna breeze through this quickly. You guys know about the cervical plexus and the trigeminal system, and it maximizes in the trigeminal ganglion. Again, so why do you have, again, the whole head, neck, jaw thing is it's the whole what we just discussed. The skull is not right, the jaw affects it, the nerves are the same. And again, headache, occipital neuralgia, dizziness. So again, if airway is compromised, the ANS reflex will prevent the ability for OA to be neutral. This is a parasympathetic dysfunction. So again, forward head posture with airway restriction, forward head, you have upper airway resistance or sleep apnea, forward head posture, inability to attain centric relation, early contralateral translation, clicking joints, TMD. That's what I find. And they come into you with a TMD, clicking joints or dropping. You see, that's the end of so this is a very interesting story. Let me get through this real quickly. 70-year-old dentist. I don't know if you guys know Raju Pada. He's in Airway, Dawson, teaching in Florham Park. Referred, he sees the toughest cases. And she had of a malocclusion. Now this poor dentist had a malocclusion since she was a student in dental school. She's 70 years old, all right? Again, long-term appliance, she's had, again, a molar crown that didn't fit right, okay? She accommodated. Long-term appliance therapy, admits that she never attained centric relation. After simple occlusion equilibration, 1 month before she came to us, her left jaw popped and the opening resulted in an onset of severe left jaw pain with eating, okay? Severe comorbidities, fragmented sleep, cannot sleep on her back, inability to breathe. Never had a sleep study, living with it, okay? Wakes every 2 hours, non-sleep, an hour and a half every 2 hours, no sleep study, morning headaches, that's another red flag, morning headache, sleep apnea. Okay, so this is her, okay, not too bad. She has a very high pain tolerance and a very high pain threshold. She's not a wuss, very, okay. So when findings, she's 29 millimeters of opening with right deflection, okay. Unable to attain centric relation, unable to attain OA neutral, secondary to inability to breathe. When I try to bring her into OA neutral, collapse. Okay, tongue weakness, tongue to tonsil was 12 millimeters. Okay, Malampati was a 3 out of 4. Stick your tongue out. Okay, severe forward head posture, posterior cranium, left jaw, left TMJ. This was a kicker too. I tried to just kind of try to get out of that trismus. Nothing happened. Hard as a bone. That muscle was in such protective mode, and I had to think about what was going on. So that was visit 1. Visit number 2, though, I said, oh, this is not gonna work. She's a UARS sleep apnea person. So I started her with the diaphragmatic breathing, the out-breath humming, the releasing the scalene, getting her to release her throat, her jaw. Tongue repositioning, relax the mandibular elevators, our USI, I have a protocol. I'm not gonna get into that tonight, no time. Dry needling. I use craniovertebral release via tongue, again, OA releasing. Did the intraoral stretch mobilization so that by the 3rd visit, okay, she, when I explained to her, she attained 37 millimeters. And again, opening without pain or deviation. And then as a dentist, when I explained to her this, she says, I can't believe my results. Yeah, so as a dentist, she could not believe the results. She understood and she benefited. So again, these are the case studies that tells us we're on the right track with this. Tongue in charge of mouth, positioning, scalloping, tongue down, ability to isolate tongue from highly. Tongue measurement, spot, tongue on spot, tongue to uvula, and then the clucking, the tongue cage is you cluck. But you suction, but you don't cluck. That's tongue cage. it gives you a measure of the length of the frenulum and the tongue base. Okay, tongue strength pointing forward, back to side of that. Again and again, I'm looking at, now all of these tongue on spot, tongue to tonsil, and tongue cave, you should be able to open to 35 millimeters. Okay, condylar rotation control there, and that measures. So there's the tongue cave. You see, there's after the low tongue posture, there's that divot there. That's tongue cave, tongue on spot, right there. So again, you measure, okay? Again, and I look at the lingual frenulum length, and I look, my thing is 16 millimeters. And if they're, lingual frenulum, 16 millimeters. And then from the tongue tip to the frenulum, 16 and 16. So again, with key myofunctional exercises, these are tongue exercises. Okay, so the 6, and you gotta strengthen, even if they're short. It could be weakness. And then if you do a tongue release that they don't need it, you're gonna make their apnea worse. So again, and I find that it's not an absolute, but it's a good way to go. So here, look at his tongue tie. Look at that, very, very short. You see, again, so there's 3 classes with that, and here's another guy, very severe, you know, and we work with them with myofunctional exercises, again, and this is Kathy. I'm gonna quick through this, looking at time here. She was evaluated, okay, max opening was 22 millimeters, 4 millimeter right deflection, lateral insertion was 9 and 4, again, jaw pain, okay, and she had the deflection, okay, this is her, okay? Now, I also look at facial asymmetry. Look at the facial asymmetry. I look up, see what they do, how far they, many things. She had right jaw pain, okay? Malampati was a 4 out of 4. Tongue on spot was 22. Remember, they should be a little bit more to 30, 35. She could not cluck her tongue, okay? Lingual frenulum was 11. Tongue tip was 17. So this is her.
Make my daughter do that.
Again, class 2 facial profile, class 2 occlusion, 4 millimeter over jet, over bite, 6 millimeter over jet, okay? And this is her tongue down posturing. That was her. Look at how she's using her. See that forward head posture, the tightness there. See, and now she's trying to hold that tongue up there, tongue on spot. Look how hard she's working her face, all right? And then, okay, my functional, let's go, the right side tongue weakness. Oh, I see, I lost the voice. Yeah, again, inability to tongue cave. You know what, it's really crazy. Adam, can I get the volume? Because the testimonials they need to hear. You see, but as you see this, look, she can't get her tongue out there. See, very difficult. I was afraid. Yeah, they have no idea. Oh, okay.
To the left.
To the left.
See right there?
Oh, it's up.
Up.
Yeah.
Can't click it.
Oh, damn. I was afraid I was gonna happen. See, but, oh. So what do you guys think? Is this all making sense? Do you guys see it in your office? Yeah. I'd love feedback.
He's the one that's.
Does it explain some of the things?
Okay, so now what you're gonna do is waggle the spikes. Point your tongue outside the lips. Good. Waggle to the right. All the way, try to reach that lid, that cheek. Good. Now waggle left. Excellent. Now the spot is you press your tongue all the way up to the roof of your mouth inside, and then now open the jaw. Hold the tongue, open the jaw. Wow. And close. Okay, so now what you're gonna do.
So there we go. So she was unable to do concave? She got to 17. Okay,
The next
and
one
then,
is you're gonna do the same thing, okay, but you're gonna slide your tongue from the spot back to your tonsils as you open.
now look at her eyes and how hard that
the
is.
tongue, stretching the jaw. So tongue on spot, let the jaw drop down on the back, keep the tongue, let go of the jaw. Slide your tongue back to your tonsils as you open. And feel the connection of the tongue, let it go, stretching the jaw muscles, pain-free. So the tongue lets go of the jaw. Decompression.
But you can see the hyoid moving.
Yeah, yes. Yeah, she said, it's amazing. That's, yeah, that's her reaction. So, again, the first session, 21:35. Power of the tongue. Okay, so again, see, oh yeah, this is a good one too. Again, he had a dental procedure a month before. Trismus, facial routine filling tooth 18. Okay, he had 29 millimeters, very restricted Malampati of 4. Okay, stick in the tongue. Yeah, this is the key. Stick in the tongue for reproduce his pain. There's his pain. And there he is. Okay, again, that was it. But now
Okay,
the
so now
next.
stick your tongue out, roll the tongue like a taco.
Tongue weakness. That's how he did. Who looks at the tongue?
Do without pain.
Yeah, so that introduced his tooth. His
Upper left. That's right, left. So starting to the left, go to the right, keep your lips, and then bring it back down.
Okay, saw him twice. That's it. Okay, now this is another one. Severe. Oh, what happened? Can you hear?
Put the mic by the,
Oh, can you hear?
Yeah.
Anybody hear it? Yeah. Testimonials about how this is so damn difficult. But the next one I really want you to hear. I was afraid this was gonna happen. You know? Almost done. I can skip the other.
I think we can hear it if everybody just listens really closely. If everybody could just listen very closely, let's try.
Can you guys hear that?
I could be a translator.
Yeah. So that, yeah, the other one is the one
Adam, can you hear it from there? Do you want to just like translate as if you're?
Or Carol, just say what she's saying.
Yeah.
I mean, this poor woman, very much like that, 40 years she's had trouble, and everywhere. And
Use the mic, use the mic.
Now in her case, she had neck pain, jaw pain, difficulty swallowing, and she commutes an hour and a half. She lives in New York, and she's been everywhere, many places, and of course it was all this oral, tongue, throat, airway stuff that I was having her do. And she said that's it. That was the first time she ever got the relief, and now we're working on course. But that was her testimonial. It's too bad. She did a good job with it. Anyways, and then in the next one here. Hold on. Yeah, it's just all right, well, let's move on. I'll just do the next. I can, if I come back, I'll include it. Okay, so let's move on.
Thank you, Adam.
Thanks, Adam. Where's my thing? Oh, I see. Okay, hold on. Okay, so I'm gonna just do a quick mention about cervicogenic dizziness. But cervicogenic dizziness is just muscle overload as well. Hyperventilation is another factor. There's an emotional component of hyperventilation and dizzy. And then the other one is ear pain, tinnitus. And there's a connection of the ear and the jaw from the embryological tissue. Eustachian tube diminishes and equalizes the pressure. Again, the malleolar bone is connected to ligament that is trigeminal related. And then again, tympanic membrane is determined by the pull of the tensor tympani, which is that oral pharynx. So let's go ahead. And then, so the thing with referral to physical therapy for tinnitus is you must have a negative ENT first, okay? And then dry needling is a critical treatment strategy to elevate parasympathetic function. That's tension, you're looking to let things go. And then key jaw, tongue, and oropharyngeal exercises are key on that as well. So here's a testimonial. I wish, yeah, I wish it, it's not gonna work. No. So basically, the ear pain was subsided by the dry needling, and then so he's talking about the muscles of the jaw that reproduced and took away his ear pain. Oropharyngeal. So, okay, so we're gonna move on from that, dry needling, let's let you walk here. Okay, again, dry needling is a form, of using a needle to affect the autonomic nervous system, specifically the parasympathetic. I've trained with the best, Janet Travell, muscles, finger points, got trained at that, went to China, acupuncture, not acupuncture, Chinese not acupuncture, came back, we trained with a group out of Alabama, Dunning, using various points and overlap between acupuncture and soft tissue. But the game changing was 2 weeks ago, we went to another course. This is a couple out of Nebraska, and they defined it. Needles can mess with your brain to produce beta endorphins, increase circulation, and you're stimulating the deficient parasympathetic nervous system. So when you're tight, what's wrong? Your parasympathetic can't shut off. The deficient parasympathetic. It's not that you're fight or flight, you can't let go. So it's not a sympathetic issue, it's a parasympathetic issue. And so when I look at these needles, and I have some here, and I say, all right, see these needles? I'm gonna go ahead and I'm gonna mess with your brain in a good way. Get rid of your pain, stimulate those beta endorphins, get you to let things go, get blood flow to your muscles, to the tissues so you can heal. Healing is about blood flow, okay? And then there's another strategy that we're doing, okay? Again, it has to do with the stimulate the parasympathetic via the vagus nerve. And again, facilitate soft tissue healing, allow you to return in 2023. We're all trained, but this is again vagus nerve stimulation. This is the vagus nerve, and game changing quickly. It just calms down the system, and it's so easy. So that's where that is. So again, we're board certified. This is our website if you're looking for a therapist that's board certified. There's 6 in the state. Feel free to look, and then answering questions. So, yeah.